know that she will join us at some point in the future. And I know you're all going to love her too. I've gotten to know Elisa over since COVID started. All things COVID might be a title for a book. I'm not sure. So again, thank you very much. We have put the questions that we have received onto slides, and Breena's going to answer those questions. You can continue to put things in the chat. We're going to try to go through all the slides first, and then we'll get to the questions in the chat. Anything we are not able to answer today, we will try to get those answers to you as soon as we can. All right, I'm not going to throw Clayton under the bus about getting this recording up because he's got some pretty hefty national obligations tonight and tomorrow. So for that, Clayton, we are forever grateful. And Dr. Holmes. All
right, and I'm going to let Clayton do the slides because that will be too distracting. I think they just arrived onto my inbox, but so hi everyone, welcome to the 15th of October. You know, we are over 6 weeks into our school year together. I did want to note on this slide that Clayton did the title. I was taught by my English teacher mother to never use exclamation points. And there isn't just one on this, there's two. So next slide. These next two slides are mine. I always lead with gratitude. You are a source of great inspiration to me, and what you've been able to do as a medical health professional during a pandemic in our school settings is completely essential and admired by me, and it's just furthered my belief that school nurses hold up the world. And then the next slide is always the disclaimer that things are still changing. I mean, luckily, this was a really important slide in March and April. I feel like we've reached a nice steady state of information. And if anything, we're getting more information to confirm our observations that children transmit the virus less efficiently than adults. There's a very good study coming out in pediatrics this week that I got a preview on that shows there's essentially no transmission in childcare around the country. And they studied, 58,000 children and several hundred cases that were in the kids who were childcare age, but the transmission was not in the center or the home. So that's going to be a great study. Next slide. Just want to talk, this was the list that came from your leadership, or maybe from you as well, that you wanted to we'll do a little situational awareness of where we find ourselves today. And then, yeah, I'll gladly address the Vermont Digger article. So the school cases to date, it's actually been a fascinating few weeks. Every single case that pops up in a school is somebody that had a close contact with someone with COVID. So these are very easy epi links, they're called. When the case is found, we say, oh, that's the son or daughter, or that's a teacher who's associated with that case, and so on. So it's very affirming that the work in the building is preventing the spread, but we're still having episodic cases find their way in. And to date, the children that are asked to quarantine are not ending up with the virus. So, but that doesn't mean it hasn't been disruptive. And if those of you that have been through it are going to become quite important to each other, and the whole journey of how the health department gets together quickly with administrator, COVID coordinator, school nurse, talks through the exposure, talks through the line list, begins the contact tracing. Sharon Lee and I have been a part of it, and it's exhausting. And it's very, it's always at night. It's often on a Sunday, but it's the right thing to do. And then you got to communicate like crazy and then get everybody to just follow the plan. The hockey center case is going to grow over the next few days. It is associated with several of the kids you're hearing about in school as well. So there's overlap that will become clearer. I would encourage you to tune into the press conference tomorrow. We're now in the 15, 18, 19, 20 case range, and it's a lot of adults. So this was not anything I guess I'll say publicly, the center did a lot of things right. It isn't the physical building of that center, but there were teams that moved about together in a way that didn't have all of the best public health in place. So, but it's got tentacles, and you're going to hear about it for days to come. And then the digger. So I don't know what this was. I didn't find this article to be helpful personally. I thought it was a little glib or flippy and not very sciencey. And I don't know where that sentence came from that Clayton put on this slide. So I guess one of the things we'll talk about for a long time to come together is the role the media has played both in the state and in the country about COVID. And I think the more things roll on in Vermont, from my perspective, the more most of us as citizens are able to kind of temper what we're reading and turn back to the press conference and listen to Dr. Levine, because yeah, I guess it's creating havoc. I mean, you guys have certainly been, we understand that ill children being excluded is problematic, but I don't really like the language that creates havoc. And, you know, it's really about preventing a virus. So I wish it had been framed more in a kind of general infectious disease principles kind of way, that we should have been doing this for decades. And the fact that we have the poor social policies that don't support families to be home when their children are sick should have been highlighted in this. And it could have been a great opportunity to talk about, you know, the care of our children. But next slide. Be really interested in your take too, as folks that are having these conversations every day with families. This is a great question. We talked about this months ago, but I'm glad to come back to it, that headache is a super common symptom. It's also on the COVID list. And the answer is no. This is why I love school nurses. With your background, education, and critical thinking skills, decision-making skills, you're absolutely in the position to say this is not a COVID-associated headache. I've known Sarah for 6 years, since she was in the 4th grade, and she always gets headaches in the fall, or she's having a difficult time and she's dehydrated. This is a boy that never hydrates. This is a kid that drinks too many energy drinks. You know, the list is endless, and I would really encourage you to bring forth your clinical skills. And I imagine, you know, you do see what's interesting about COVID for Sharon Lee and us at the health department and me is there's some literal like all that critical thinking, decision making that we all have been doing for years. Some people just blocked it and now just want everything in writing, everything black and white, everything interpreted to the letter, which is really just a personality quality. It's nothing about our guidance, and it's certainly not anything about how I feel about you as a profession. So if you're feeling like someone's pressuring you to be literal, then you do need a conversation that a headache is on the list. That is true, but it's also extremely common. Next slide. Okay, here's the distance story. The guidance, Soph and I have been working hard to revise the guidance, and it's almost done. And then it will go to Dr. Levine and Secretary French, but tomorrow, probably for the weekend review, and we're hoping it can be published next week. Every time I say that, though, the Agency of Education has a different timeline. So I don't know, so maybe the end of October, soon, October. And as you can tell, I can tell from the question, the preview here that we've extended the 3-foot minimum distance from pre-K to grade 6 now, which is great. And that we know that that's true of meals as well. So even though a student from pre-K through 6 is taking her mask off, it is still okay to be 3 feet apart. And what we're recommending is that folks be efficient about the meal, like everyone is, right? You keep the mask on during the prep, the hand washing, the getting the meal. You sit back to your table, you take the mask off, you eat. And so if we've had good talks at the task force, how long does it take a child to eat is variable, and then put the mask back on and go for it. So it is 3 feet for eating, even without a mask, but not an inch shorter than 3 feet. This is the ceiling, the bench. This is the bar, 3 feet. Does the use of plexiglass decrease the minimum 3 feet rule? And if so, what's the minimum distance between students? Okay. I am going to answer this question recognizing that it may, there are some interpretations of this that are different at the school building level. Plexiglass does not decrease the 3 feet rule. However, today, I discussed with Patsy Kelso, the state epidemiologist, could you be less than 6 feet apart in the older kids with plexiglass? Yes. So there's some nuance here. 3 feet is the minimum. But since we say 6 feet for older kids, they can use plexiglass to get older kids closer. So it's a yes and answer. I hope that this gets codified this way. I should caution us when I answer that it is my best understanding today. And there are forces at play that Soph knows a lot about, that we make decisions, and then sometimes someone says that's not what's going to be in the guidance. So I'm explaining it to the best of my understanding right now. And I think I answered the reduced spacing for eating and drinking. It's 3 feet for eating and drinking, but the older kids can eat and drink closer than 6 feet if plexiglass. Next slide. Okay, hot topic. It's almost like these questions were given to Soph, and now Soph gives them to the task force. We are wordsmithing this right now. Let me tell you the origin, just for the heck of it. The docs were fussing at the beginning that it was a tremendous administrative burden, especially for childcare, to have to write a letter every single time it was okay for a kid to go back to childcare. And I am very responsive to my pediatric colleagues, and I put into the guidance that this has to be a dialogue communication. It does not have to be some big administrative burden. Then schools opened. We worked diligently on an algorithm that clearly states for a certain subset of Vermont's children, medical home school nurses need to communicate in order to clear. Doctors hate the term clear, so I'm just going to say in order to welcome a student back to the school, and that is the algorithm with that disposition document that many of you have altered, edited for your own communities. That document is the clearance letter. And we don't know how to say all these sentences without, because what we really want, and you guys all know this, we want medical homes and school nurses to discuss what's going to happen because Johnny has strep throat and now after antibiotic, he's coming back tomorrow. But to me, that's a phone call. A care coordinator or a great nurse at the pediatric office picks up the phone and calls Becca and says, I saw 2 kids from your school today and they're both coming back. It doesn't have to be a signed doctor's note. That's the language that's inflammatory for the docs. It sounds just like so much work. So we're going to try to say something like, there must be communication with school nurses in certain parts of the algorithm, not all, because there is a column where kids have just the one symptom and feel better. So that's my way too many sentences to explain what we were trying to do and why it backfired. So it's not that we don't think there needs to be communication. We just didn't want to require, and we didn't want your administrators either to be like, every kid needs a file with a note. We just thought it was team-based care and that you guys at your community level could figure out the best way to communicate among you. Next slide. Okay, this is a good one. I saw this question ahead of time, thanks to Clayton, and I don't really know exactly what to tell you about this. I mean, indoor rules are clear, 75 kids, and I guess, so, and there's nothing in the guidance that would preclude that. We actually say in the guidance to follow the ACCD rules for group size. I'll tell you the awkwardness though, and I really don't want you to have to go here. The ACCD rules talks about square footage. It's actually pretty mathematical that it's like a kid for every 100. I don't know. Maybe Soph can look, or Clayton can look it up while we're talking. So I don't know how many kids your gym can hold to all be with the radius at ACCD. So I think you should probably think about that. It's definitely not 25. So that is old. I appreciate you recognizing the origin. But it's definitely not more than 75. And if your gym's too small, you're not going to be able to get 75. And so the grade level question here is really about the space size. So, and they've never really wanted to go any further with that because there's so many variables for assembling, but schools are awesome and you're wearing masks and you've worked out some better ventilation, so it isn't the same as putting a bunch of people into the basement of a Knights of Columbus Hall, you know? So that's as best I can answer that one. Next question. Okay, this question about, and I guess I should read the questions for those not on. I realize now you're not all on the Zoom, the visual. How many students who are exhibiting symptoms can I have in my isolation room, and how much distance does there need to be between them if more than one is allowed? No partitions or screens. I would really count on your colleagues who are doing this to answer that. You have to be at least 6 feet, the kids, and masked, but I would prefer a partition or a screen. I don't know if Clayton or anyone, Becca, you want to answer this? You've heard Soph talk about she's putting everybody outside. I don't know, you know, to try to really just minimize exposure. Go ahead.
Yeah, the only thing I can say is that in our school district, the gyms have the best ventilation, and so that's our overflow area. So if we have more than one student that needs the isolation room, then outside's our first venue. But if it becomes too much to handle having someone in the isolation room and outside, then the gym becomes our overflow area. So I think having a plan in place is the most important part.
That sounds great to me. Good answer. Next slide. Okay. I think Soph and I are prepared to say publicly that we advocated for temperature being taken at home as more like a hybrid, that maybe you could get a bunch of kids screened as part of their health screening in their homes, and then there would be a group of kids who would still need it to be done at the building. We were overruled by the administration, not by the task force. And it's, you know, it's as you know, in public policy, you have to decide when you're going to fight and when you're going to say, okay. And the governor and his team like temperature taking at school, and they've heard a lot from constituents about that, and they want that done. So the cold temperature means you're going to have to go inside, because the thermometers don't work under 60 degrees, which you've already figured out, and you already have given us really important feedback. So again, I'd like you to be a team here and get technical assistance from each other, because you know, Sharon Lee and I, ahead of the task force, and so if we queried other states and our pals around the country that do school health, school nurse leadership, and all of these things you list on this slide are happening. Some people are doing classrooms. I don't love that one because there's been a lot of exposure potential. The car, I've heard some interesting things that they're requiring families to get the temperature of the car above 60 upon pulling up, and I don't know how you do that, but and then, you know, definitely gym. Some sort of like airport. This is Sharon Lee's notion of like an airport with the rope line, and you just get everybody in and get it going. I just really want to acknowledge how hard this is, and but I also want you to know that your team, the task force team with all the great thinkers on it, didn't want to forego it entirely, which is another pathway that a lot of states are opting for, and it remains a objective data point. I think many of you have fed back to Soph that you found absolutely no one with fever in 7 weeks, and it is a colossal waste of time, and I hear you. I just know that it also is kind of a optics thing, and it slows everyone down, and they take a minute to just get a second to say, we got to just figure out what this one objective data point is. So it has we can revisit. I'm hopeful we get to pull the team back. You know, we get kind of told when the task force can reconvene, and my goal would be December, because this Thanksgiving thing is going to be interesting. And then but maybe by then we'll have more stories from you all about how this does or doesn't work. So keep the feedback coming is a really important piece of this. There's nothing static. Next slide.
So, Dr. Holmes, I think we're going to try to loop back to the 3 foot, 6 foot questions for a second. Becca has a couple that aren't on the slides that she wanted to ask. Thanks.
Great.
So the first question you already addressed about is reduced spacing allowed when eating and drinking. And so I think you addressed that pretty clearly. It's 3 feet minimum. And then what consequences or processes have been put into place to ensure schools are doing their best to maintain distance and not just packing students in at less than 3 feet without barriers?
Yeah, that's the question of the hour. Your great leader, Soph, is going to address this at the Secretary's Advisory Group tomorrow with the Secretary of Education and other school leaders. So, you know, we in public health, we just state very clearly what the science tells us to state. And the whole journey of implementation, interpretation, and the way that schools are functioning is separate from that. And that's not to say I don't, you know, come and talk to people and meet with teachers, but I do want to be clear that there's a lot of language around COVID about feasibility and whenever possible and do the best you can, that's coming up against like this sense of a hard stop at 3 feet. And that's the space you find yourselves in right now. And there's such interesting reality with the littlest. You know, we're obviously recognizing this 3 foot story is the pre-K 6. Think about our childcare experience, or maybe you have had experience in childcare. There's no distancing in childcare. And we knew it, and we didn't want to set everyone up to fail, but we also had to put some guardrails. And we told childcare providers to just do the best they could. So there's a funny gray zone, muddy pond here of our experience in kids in the childcare environments and then school environments. And, you know, I've talked with your leadership about this. You have great thinkers, and I'm uncharacteristically coming up a little short. So tomorrow's conversation is going to be interesting in that, you know, the regulatory piece of it, because what we've learned from the cases in schools is schools are incredible. What people are doing to protect their staff and students is exactly what they're being asked to do. And it's been so heartening to sit and watch my contact tracing team, who don't have anything to do with the guidance or anything to do with all the technical assistance we've been doing with you all, just meet school teams for the first time, and with school nurses in the center, and take them and just interview them. Did you do this? Did you do that? Did you do that? It's just really heartening. So I'm going to try to stay strength-based, recognizing that you're witnessing some other things.
And then the other question is, in the original guidance, schools were asked to set and post capacity limits for each classroom. What if the capacity exceeds what was posted at the beginning of the school year?
Okay, I need a little more information. That might reference the earlier slide. That I don't recall capacity limits. Did we say 25? Is that what? If the person who wrote that question could clarify. Oh, okay.
In the original guidance, the schools were asked to measure square footage of the room and then post outside the room how many people were allowed to be in there max. And so the question now is—
Well, I just want to be clear that the guidance didn't tell you to do that, though. That was a decision at the school building. We never addressed. We did say you should reference the ACCD capacity, but we didn't say anything about assessing a classroom or posting, because that level of specificity was determined by schools. That's not a terrible idea, but that was not in my wheelhouse.
That was in the maintenance people's wheelhouse. So it's people we're working with on.
Interesting.
Teams.
Okay, good.
And so now we have these posted capacities. And so what do we do now when the capacity is over the limit? of what's posted.
Yeah, I think this all starts by like making sure that you understand the origin of the capacity, because if it's the guidance, we don't say 25 anymore. It's looking at this ACCD square footage, but that's for indoor spaces when people are going to be more than 75, you know, or when people are going indoors up to 75. So it's actually not quite, we did not actually address this specifically the way you're, but it's something that I should look into and think about with you. I didn't realize that was occurring to that level of specificity. And Sharon Lee's putting in the chat appropriately, what does it say in VOSHA? I really don't know about that, but so let's do a little work on this.
And if I could just add,
So
so
that,
if
yeah.
when you look at this, if you say that each student with 3 feet needs 27 square feet per, you can figure out pretty quickly how many you can fit in a room at 27 square feet per student. The other part that isn't really addressed is even though students pre-K through 6 can be 3 feet apart, staff members still need to maintain the 6 foot. And when we're putting so many students in a classroom, especially when they're unmasked for eating, the staff members may not have the 6 foot distance just because of the capacity of how many students are now in the room, or because you have so many staff members along with the students, it's very hard to maintain that 6 foot distancing for the adults. And so that's just something that's a consideration for the part that Becca was just talking about with, if we can go above 25, that's fine. But math is math. If you have 27 square feet and you have 270 square feet total, you can have 10 kids, right? I mean,
Well, I just want to caution you though that we're not talking about a circumference. You know, this is a very complicated topic, because when the two infectious disease doctors started looking at all the literature and recognizing with inefficient spread, the 3 feet distance was safe for kids. They meant kids sitting side by side facing forward. They didn't say it had to be 3 feet behind, 3 feet to the left, 3 feet to the right. You know, they were just talking about a general principle that if you're facing forward, there shouldn't be someone 3 feet to your right, you know, if you're against a wall, or, you know, it's that. So that I think when you're doing your math, Clayton, there's something going on here about circumference or what, I don't know where you got 27, but, and then the other thing is the adults, yes, when possible, be 6 feet from your students, but teachers, we know from the contact tracing and the cases, teachers are back and forth way, way shorter than 3 feet and back. And that's all allowable in the guidance, because it's a do the best you can, because you got to teach and move about and go side by side with a student who you're helping with reading. And so what's happening when we talk about this as a team, you guys are coming up against something significant with your administrations, and it feels very relational to me, that we have to figure out a way to get teams to get in a room together and talk about what feels safe and interpretations of the guidance, because I don't think the math is going to be the end and be all here. I think this is, it's too fluid with the way classrooms move, especially with our childcare experience, you know. So I'm probably talking too much. I don't know exactly how to proceed, but I think Soph's going to get some really good dialogue going about this tomorrow with people beyond health, because, you know, health is, we're sort of used to this kind of flow of an individual environment, but we're talking about a whole system here with schools, and so many of you have come forth with this concern that it does feel like it needs more attention. And it's not what I expected, so it's just the way COVID goes. I thought there would be that ongoing alignment between you as the COVID coordinators, or at least as the health experts, and your administrations. Back to slides?
yes, we are. Thank you.
Okay. All right. Interesting. COVID testing in schools is a hot topic. You guys are leading edge thinkers. Just wanted to make sure you knew that. So there are many people who would like intermittent available testing for adults that work in schools. I'm not one of them, because I don't understand how that would work. I believe it would have some minimal surveillance opportunity, but we have less than 1% of all our tests come back positive, and that's when we're testing the vast majority of people who have a reason to be tested, either symptoms or close contacts. So if we were to look at a whole population, if we were to line up 50,000 Vermonters in a room, we would find one positive this particular day in this current low prevalence state. So if we start just randomly testing teachers, you know, I guess we might find one case in the next 6 months, but to what end, right? And so it's not an approach that lines up with my scientific head and my public health, but there are political reasons to do it, for folks to feel that they have access. I think the place I'd like to put my energy, and I am putting my energy, is to have adequate testing capacity in all of our communities for the worried well, people wanting to get out of quarantine, symptomatic people, and close contacts. And that may or may not be associated with schools, but it is the right way to have adequate. And what we're hearing, and I'd be super interested to hear from you, some communities are rocking this. You want to test, you call your doc, or you go to a pop-up and you get it at 3 p.m., you get your results the next day. It's like this just perfect system. And other communities aren't having as much success. There's a lot of like backlog, the call goes in, nobody calls back for 2 days. Getting results is challenging in some communities. People are looking, they have to log into portals, which is not everyone's skill set. So I hope that answers it. I'll also use this slide as an opportunity to tell you about antigen testing, which is the rapid, it's very different biology than the PCR, which is a gold standard test. The rapid antigen tests are getting more and more available, and they're more and more popular. They have false positive rates, especially in a state like ours where we have such low prevalence of the virus, and they're really unreliable when you don't have symptoms. So if you have an asymptomatic person with a positive antigen test, well, we're recommending all antigen tests be backed up with PCR, and at least once a day. My team tells, you know, the health department team tells me that there's a positive antigen test with a negative PCR, and there's a couple of days in between. By the way, I have a fly landing on my head. I don't want anyone to think I'm Mike Pence. Next slide. Okay, this one's important to me as well, because you can see I have such great faith in you. We knew this was not perfect language, but we had no idea what to do about it, because you can't say symptoms have completely resolved, because if it's one symptom, this is the right-hand side of the algorithm where we're letting kids have just the one symptom, and then they can go back when they're improving. I can't say resolved, because it could be just a little ache, or even the little dreaded runny nose that's improving. So I define improvement in pediatric healthcare as you're drinking well, you're eating well, you're sleeping well, your mood is great, your energy is fine, and the symptom persists. So it's just a medical thing, which I think you have in your brain somewhere. I think we just have to get back to basic principles. Like, how would you define it if it wasn't COVID? What would it look like to you to have a child returning to school improved? And it's sleeping, eating, drinking, and mood. Wish somebody was videotaping this. Oh, you are. Okay, next slide. Yeah. I just want you to know, so those that aren't on, sorry, I'm not reading the slides. School nurses are getting pushback from parents about sending kids home for minor but possible COVID symptoms. 3 things. 1, the pediatric healthcare system has your back. And if you don't feel they have your back, I need to know. So I'm going to speak in generalities because I love my colleagues and I think that they get this and they will support you. But I'm also hearing stories about little quirky little people that I don't know very well, or medical people are saying, oh, come on, send the kid back, or you shouldn't have sent him home. So if you're having those dynamics, we're a small enough state that I should really know about that. And then also your school liaison, that wonderful nurse that works in your district office, I hope you've been in touch with, because the communication between home, medical home, school nurse, the nexus of that, I think, is the school liaison. To think about how do we want to function as a team, and then if it's breaking down, they do have the resources. They have a district director and they know the medical community, and they can do some of the advocacy to a certain group. You know, we've heard there's some docs out there that are making trouble. The latest one we heard is some of the docs are telling teachers, the adult doctors, telling their teacher patients, quarantine if they hear there's a case in school. And I have been messaging to all my medical colleagues, wait, hold on one second. You don't determine who quarantines. That's contact tracers. And if a teacher was going to be advised to be quarantined, she would have already been called. So that's not a doctor's decision, right? So next slide. Interesting. This is also a new one for me. So we're so proud of the question is, are there resources for situations where a family has a high deductible, can't afford to take children for an evaluation? This one's heartbreaking. We pride ourselves in Vermont on the best health access and the highest rate of insured children in the country. But this is the exact situation that doesn't appear in the data. So you can have all the health insurance in the world, but if you have a high deductible, your access is limited. So I don't have a resource on hand. I'm going to ask Sharon Lee to take note of this. We do have free care opportunities. Sharon Lee saying in the chat, Dr. Dinosaur can help. Again, I would contact your district office about this because we can get access to some of the Medicaid policy and figure out if there's a pathway here, because that should not be the path, that a child can't be evaluated, because the equity issue here would be large, right? That then there'd be a group of kids who can't figure out a path back to school with illness, which is so unlikely to be COVID, and that's not our belief in Vermont. So I'd like to figure that one out. Go ahead. Yeah.
So the reason that I sent to you last week or the week before the free and reduced lunch or the federal poverty rates link and documents, I will resend them, but those tools are very helpful when a family says to you, I don't qualify. I just used to have just a copy of that and say, look, and they'd go, oh, I could get Dr. Dinosaur and it would cover those things that my other policy doesn't cover. So I'm happy to send that again. And we'll include the health access link as well. Thanks.
Great. Thank you, Sharon Lee. Next slide is PE and gymnasium. Okay.
This is
See if I don't think I have page 20. Yeah, no, this is confusing to me. So it was typed in that guidance for indoor PE and gym use, step 2 to step 3. The bullet says, if possible, keep communal use space such as cafeteria and gyms closed. That's not true. The whole point of step 3 is you can open cafeterias and gyms. So I don't know what that bullet means. That is the step 2 guidance. So if it's page 20, we can certainly double back. And if used for their intended purpose in small groups, staggering use, cleaning and disinfecting. So I guess I'm wondering what the question is here. And if
Breena, this is Soph. I think it's twofold. One is this is the wording from the guidance under step 3. It says they may be used for their intended purpose. However, it does say, if possible, keep them closed.
Well, that sounds like a I mean, I think what they mean, I know what we mean. We mean that you don't use it as a place for people to congregate and to bring large groups together unless you're intending it that way, and for PE and eating. So I guess we still have time, so to fix this, to make it more clear, because and then the other thing that's changing, there was some early guidance that you had to wait an hour between groups in cafeterias and gyms, and that is now we're just recommending that groups come in and go out a different way so they're not passing each other, but that the gyms and cafeterias can be used sequentially. I was interested in this question. What specific symptoms or combo of symptoms require teachers and staff to remain at home and for how long? I tried to be the convener of the adult infectious disease and adult primary care to get an algorithm going for adults that would include teachers. It's not intended for just schools. And it's in the 11th hour. We have an algorithm. It's extremely complicated because adult doctors are different than pediatricians to work with, in my observation. I sent it to the EPI team. It's now being reviewed by primary care in a few communities that were willing to kind of play it out as the keeper of the medical side of it. So, we're very lucky in pediatric healthcare that the infectious disease doctors were able to make sort of a major minor symptom demarcation in the algorithm, where if it really was fever, shortness of breath, loss of taste and smell, like that's just go straight to test because those are really high major symptoms in pediatric COVID. But the adult doctors couldn't do that with adult COVID. They weren't willing to say, this set of symptoms takes you this way. They just said those symptoms are all on the list and they could all be COVID. So the algorithm is much more about pathways to testing. So this must be hard for you all that you're sort of in this adult world as well. And there's no talk in the algorithm about like who goes back when. It's more about who gets tested when. And so I think it's really symptom resolution that's going to bring people back. It's not going to be as nuanced as kids, but I'm hopeful to have something I can show you next week, but it's been much more complicated than I expected. Next slide.
So that's all the prepared questions that we had.
Okay.
There are some in the chat box that maybe we could address. So if the one I sent you that I just texted you, if you could look at that one, maybe read that one to Breena first, and then I can try to unshare my screen for a second. I might be able to pop a couple more questions in the PowerPoint while you're reading that one to Breena.
Great.
Okay. So Breena, this question is, can you help the school nurses with the questions that are arising for them around travel and around people leaving the state under essential reasons, maybe caring for somebody else or going to a medical appointment, and then returning to work? It sounds like
Yeah. So Sharon, the team at the health department are the absolute experts in quarantining now. So it isn't perfect, but people that go out of state for medical appointments, or there's a nice solid list in the FAQ on the health department website. Kids with shared custody, people who have to do medical appointments, go care for someone under, a caregiving role. They do not have to quarantine, even if they come back from a red zone. And it's just we're hoping this just little narrow group of people that really respect the risk of that, but can go to work. And then everybody else really shouldn't travel. And if they do, they have to quarantine. And I've told many groups this week. This is going to be the topic that changes our prevalence. There is no doubt, because we don't have the virus to any extent in this state right now. But people are itchy and they want to, and some of the, without Dr. Levine doesn't go very far in describing this in the press conferences, but there are several sort of started case loops from someone leaving the state and coming back and not quarantining. And I'm sure you've seen the press conferences, because the governor gets asked about punitive, why aren't we meeting people at the border, checking license plates, and it's not going to happen. That's not a Vermont way. So I hope that answers the question. And Sharon Lee's typing in appropriately. It's just the person that does the travel that needs the reason to go. If you bring the whole family down and just dad's getting his appointment, the family has to quarantine. They shouldn't have gone with them, essentially. It's the person that had the essential appointment that gets the waiver, as it were.
Breena, I know that you're aware of this. We've seen a rise in incidents in the state, and we've also seen the increasing yellow and red zones around us. And those communities that sit on the border of some of those yellow and red zones, there's increasing concern about what you just mentioned, an increase in travel to and from, and a complacency that we often talk about not wanting to see, that we just have to be vigilant. But I'm wondering if you have any thoughts on how we can address that.
Yeah, I just, we should be worried, which isn't really my normal demeanor, but it is ever increasing number of states and counties closer and closer to Vermont that are red and yellow. And, you know, I think we just have a lot of responsibility as citizens.
Mm-hmm.
And then we also have to really encourage people to do the right thing. So the example with custody, you know, and you guys all share my belief that we're not going to punish a child who has parents in 2 states by saying every time you go see someone you love, you have to stay home for 14 days. So that's never going to change. That's a policy. But schools are concerned about it. And what we say is that those children and their caregivers need just a lot of support to be reminded that this is a risk to the whole population, and that the exposure needs to be minimized when the child is visiting. So it's just a lot of relational work here, and it's also good public engagement. You know, I think the health department is going to do a big push in the next 2 weeks about travel. Don't do it. And they're going to sort of make it such that school administrators can use it to message to families and teachers as well that this is not going to be a normal Thanksgiving. So, and if people move about the way they normally do, we're going to find ourselves with a lot of cases.
So I do, the slides that back up, if you can see that, Dr. Holmes, I do have 3 more questions on 3 slides, and then we'll probably have to shift back to the chat box again. Yeah,
I can do this one. We get this question, again, you guys are the leading edge thinkers. This isn't going to work in our current prevalence to have one person get the test and everybody gets to assume in a family that they have the same result. And it's not going to work for a few reasons. One, because of the way people move about. You know, you can't assume that a child's exposure is the same as a parent. And what we've heard from our medical folks is they're testing the sickest person, which is also really problematic, because the sickest person might actually be the one that's the most isolated and that other folks are moving about. And so if it ends up that's a short way of answering a long question, which is we have plenty of testing capacity right now in Vermont and plenty of supplies. So anyone you think might have COVID should have his own test. And a negative test of one person doesn't clear the household to move about. So I think if testing capacity gets limited again, we might suggest some sort of household sentinel tester. But for now, we're recommending everyone that you're curious, you know, everyone that wants to know needs his own test. Next slide. Yeah, so the gym stuff is, so one of the most interesting parts of getting the task force back together for me was the transmission risk and concerns for touch is way down the list now in the infectious disease brains. It's all respiratory spread. So all of the modifications and accommodations we made early on about schools, like don't share markers, library books quarantine for 72 hours, no basketballs, don't touch that surface, wipe down the playground, it's all gone. So the next revision is going to say, like, you know, wash your hands, then play basketball, and then wash your hands again. So the activities in the gym about any kind of equipment are going to be allowable. This question may be asking, what about sort of running and breathing heavy? And there's some guidance from the AOE about PE that we're standing by, which is you do want to minimize the exertion even with masks. which is a little paradoxical if you think about all the fall sports we're allowing, but we're nothing if we're not loaded with paradox in COVID. It's just, you know, trying to minimize in one area and then allowing in another. I think winter sports is going to be a doozer because fall sports are outside. So I can easily have them be a little different than the indoor PE.
So
But
Doug,
I have no idea what's coming with winter sports, but they're all indoors, as you know.
so a follow-up to that would be, we've seen where the administration or others have tried to apply the fall sports program piece on what the guidance, because it's kind of separate from the guidance in some ways of how that applies to PE or recess. And so is the guidance document specific to those two for recess and PE, and then the fall sports program is really for the after school portion of that.
That's
Can
correct.
they be, they're not interchangeable necessarily, or can they be within reason? That's what people are talking about.
No, the fall sports is all outside, and we were very clear on that, and that's guidance that comes out of you know, natural resources and Julie Moore with the, you know, great infectious disease guys on it. And then the school guidance is ours, but we don't say a lot about PE in the strong and healthy start guidance. It's the supplemental FAQ from AOE that really, or I don't even know that they would consider it an FAQ, but that really addresses physical education. Okay, next.
So that's all I had. So Becca, if you have
Good. Okay.
that's all I had in there, and we have about 6 minutes left. So want to make sure if we have something in the chat box that came to mind, Sharon Lee or Becca, that'd be great.
So the first one is, do you recommend kids not talk during lunchtime when masks are off as they eat? I see classrooms with no speaking rules and some are the opposite.
Yeah, I don't have a strong feeling about that because this is limited exposure, it's brief, and it's one of the biggest things we learned in childcare is we don't want to attach too many punitive rules on a group of kids that are already stressed and aware that they're constantly doing things that are being reprimanded by adults. So I think kids can talk, sit down, eat, talk, and then get the mouse back on and get back to business. I think it's more about the efficiency of the journey than about the activity during the unmasked time. I don't want kids languishing and moving about for 20, 25 minutes. I'd like 20, 25 minutes to be the cap on, but that's very arbitrary, and I'm just saying it as a practical matter. It's not we don't say things like that in guidance because it's so hard to be the person that's trying to monitor all this. But little kids don't, you know, the studies we've talked about this a lot as a group about why aren't little kids transmitting this virus with efficiency? They just don't have the force of particles. That's one of the major theories about their transmission inefficiency is they don't cough or talk the way we do, you know, with that force. So, but that is why we're really still not allowing singing, which is such a bummer.
That's the next question. You must have read our minds.
Oh.
Are chorus and singing groups allowed to practice if outside and 6 feet apart and without masks? Music teachers are struggling with not being able to perform, but athletes are allowed to
I know.
do that.
I'm so glad this came up. So yes, you can sing outside, distance and unmasked, although I'd rather you be masked and still sing. But outside is fine, inside is not. Our task force is acutely aware of, yet again, our society valuing athletics over the arts. And we have a great group of thinkers, and it's come up several times. So as we move toward winter sports guidance, which is due out shortly, there's growing feeling among the task force that we want to continue to try to figure out a safe way to get the arts back indoors. But because you're my scientist friends, there was that outbreak in Washington State at the beginning of the pandemic with the choir at church has really set everybody back because, you know, 30, 40, 50 people got the virus from a big old sing fest. So To be continued. And the music teacher associations, both nationally and in Vermont, are awesome, incredible communicators, very calmly. They just every week send us their latest research, their latest thinking to the Agency of Ed, to me, and they just want audience for this ongoing need to get kids back to their joy spots. And we're working on it. It's just not easy.
Okay.
So we're down to just a couple minutes left. I just wanted to give you that heads up, Becca.
Breena, we've had a lot of questions come in, 2 questions, excuse me, on creative ways to do parent conferences. I know that some LEAs are already doing parent conferences and have figured out how to do it kind of, flexibly within a limited time period, like 2 weeks or something like that. But confidentiality and spacing. Wonder if other folks have ideas.
Clayton, do you want to ask your question?
Yeah, so I'm sorry this might be the last one, but some districts are using bus drivers that are from out of state because they don't have any in-state that can fill those positions. Would they be considered essential workers from that standpoint to meet those requirements, or because of their out-of-state quarantining, is that going to become a problem?
Teachers can come from another state and work in Vermont, so bus drivers would be allowed as well.
Fabulous.
And
okay.
there are many school districts where the teachers come from red zones to work. I don't like saying that out loud, but it is true.
Okay. So Becca, you want to wrap?
Sure. Soph had to leave early, so I'm here to say thank you for being here, and we will be in touch about future programming. And as the new guidance comes out, please always email your questions to COVID-19 at VSSNA. We're here for you. As always, the recording will be posted, probably not tonight, as Soph said in the beginning, because Clayton is on national meetings both tonight and tomorrow, representing us at the national level. So again, thank you, Clayton. And Breena and Sharon Lee, thank you so much for being here with us. And Breena, thanks for being our champion as always. We totally appreciate you being here and having our backs as school nurses. And a special thank you for changing your schedule and backing Soph in meetings tomorrow. So thank you so much.
All right. Thanks, everyone. Keep up the good work. It's been a very successful start.